Good morning, friends. Today we discuss juvenile diabetes mellitus. Diabetes mellitus is also known as childhood diabetes mellitus or the juvenile diabetes mellitus or the growth onset diabetes mellitus. Type 1 diabetes mellitus is known as Madhumeha, which is described as under the Vatach Primeha by the Acharya Charak, Acharya Sushrut, Acharya Vagbhat, and other Acharyas described it under the Vatach Primeha. Introductions. Today it is the commonest endocrine metabolic disorders which is characterized by a wide range of the metabolic abnormalities of the carbohydrate, protein and fat. Effect on child physical and emotional development. Diabetes mellitus is a chronic disease characterized by hyperglycemia and glycosuria. What are the incidences? Childhood diabetes account for about 5% of the total population of the diabetes. In India, about 4 lakh infant and children suffer from diabetes mellitus or 10.5 per million per year. It is not common in infant, increase in frequency until adolescence and then drops sharply. It has two definite peaks, one at a age of 5 years and other are about age of 10 to 12 years. Seasonal variations, children being diagnosed more often in the winters than the summer month. Susceptibility to type 1 diabetes mellitus, changes in geographically and lifestyle. No correlation with the socioeconomic status. Diabetes can affect in any socioeconomic status. Now we difference the childhood diabetes versus the adult diabetes. Childhood diabetes is usually rapid in onset, often first presenting as a diabetic coma. Onset in case of the adult diabetes, it is insidious. Unlike adult diabetes, obesity plays no role in the child diabetes. Children always need injectable insulin. Most adults with diabetes respond to oral hypoglycemic agents, and diabetes control alone never works in diabetic children. On the basis of etiology, diabetes is of four types. Number one, type 1 diabetes, which occurs due to the destruction of beta cells. It is of two types, immune mediated, and second one is the idiopathic. The second diabetes is type 2 diabetes mellitus or non-insulin dependent diabetes mellitus. Third is other specific types of diabetes mellitus such as genetic defect of the beta cells function, genetic defect in insulin actions, disease of the exocrine pancreas, endocrinopathies such as acromegaly, Cushing syndrome, hyperthyroidism, hyperthyroidism, etc. Drug or chemical induced diabetes mellitus, pentamidine, steroids, thiazides, and diazoxide. Infections induced diabetes mellitus such as congenital rubella and cytomegalovirus. Uncommon form of immune mediated diabetes mellitus, anti-insulin receptor antibodies are occurs. That's why it happened. Other genetic syndromes sometimes associated with diabetes such as Down's syndrome, Klinefelter syndrome and Turner syndrome. And the last one is the gestational diabetes mellitus. In this, the diabetes appears during the pregnancy and later on the pregnancy has been completed and the diabetes mellitus disappears. What are the difference between the type 1 diabetes and the type 2 diabetes? First of all, we know the type 1 diabetes where the destruction of the beta cells occurs and it is known as insulin dependent diabetes mellitus, and type 2 diabetes where the functions of the beta receptors is reduced for insulin and the production of the insulin is affected, and it is a non-insulin dependent diabetes mellitus. The onset of type 1 diabetes is rapid and obvious, while the type 2 is slow and insidious. Age of onset is below 30 years of age in type of 1 diabetes, and type 2 diabetes always occurs after the age of 30 years. Obesity plays no role in insulin dependent diabetes mellitus, while it plays a role in type 2 diabetes mellitus. Association in the HLA-DR3 and 4, that is 2.5 times, is more in case of the insulin diabetes mellitus or the type 1 diabetes mellitus. It is equal to the normal in case of the non-insulin dependent diabetes mellitus or type 2 diabetes mellitus. Family history play 10% role in case of the type 1 diabetes mellitus, while it is strong in case of the non-insulin dependent diabetes mellitus. Concordance in the identical twins, that is 25 to 50% in diabetes 1 diabetes mellitus, and it is nearly 100% in type 2 diabetes mellitus. Anti-isolate cell antibodies is more than 80% found in type 1 diabetes mellitus, while it is less than 5% in case of the NIDDM. Ketoacidosis is frequent in case of the type 1 diabetes mellitus, while it is absent in the type 2 diabetes mellitus. Microvascular complications are rare at onset in the type 1 diabetes mellitus, while it is present in type 2 diabetes mellitus. Need for insulin is universal in case of the type 1 diabetes mellitus, and in type 2 diabetes mellitus it is not common. Then what is the type 1 diabetes mellitus? In previous slide we see how we can differentiate the type 1 diabetes mellitus from the type 2 diabetes mellitus. Now the type 1 diabetes mellitus, it is due to the deficiency of the insulin. It is also called as insulin dependent diabetes mellitus or IDDM. It is not associated with obesity, always associated with acidosis or ketosis, occurs at any age of the life, usually before 40 years of age. Now pathogenesis. First one is the environmental factor. Infectious disease such as mumps, Coxsackie virus, B3, B4 and cytomegalovirus play an important role. Environmental toxins such as rodenticides and nitrosamine, etc. Nutrients, early introduction of the cow milk protein, free radical changes or damage play an important role in the environmental. Autoimmunity. Antigens released from the beta cells are seen as foreign protein by the macrophage and antigen presenting cells, which present the altered antigen to a highly specialized HAL linked receptor in a T cell, isolate cell, cytoplasmic autoantibodies, and isolate cell cytoplasmic surface autoantibodies have been described in the sera of the patient with TIDM. Another antibody is found in the nearly 40% of newly diagnosed patients is the insulin autoantibodies, that is IAA. 80% of newly diagnosed type 1 diabetes mellitus have anti-glutamatic acid decarboxylase GAD antibodies compared to 2% in control. Genetics play an important role in the type 1 diabetes mellitus. Genetic alteration, location of chromosome 6 within the major histocompatibility complex can initiate the beta cell damage. In Western world, 90% of the patients of the type 1 diabetes mellitus have at least one DR3 and DR4 antigen, and only 5% do not have any antigen. In Indian, association the DR3 has been reported. In a study, susceptibility increased with the presence of DQ beta genes. Arginine at the position of 52 in the DQ alpha gene chain has also been related to diabetes susceptibility. Annotations of the type 1 diabetes mellitus, particularly parental halotypes, 7% associated with the type 1 diabetes mellitus father and 2% associated with type 1 diabetes mellitus mother. What are the clinical manifestations? Described into the four phases. The first phase is development of the clinical symptoms such as polyuria, polydipsia, polyphagia, weight loss, often lethargy, weakness, flu-like infections. Now the second phase, which is known as phase of remission or the honeymoon phase, undergoes spontaneous decline in the exogenous insulin requirement, and duration of this insulin-free period varies from 1 month to the 2 years. This is due to improved beta cell synthesis and release of insulin after clinical stabilization. The third phase, the relapse phase, it is the interval of progressive insulin requirement, and this is due to declining endogenous insulin secretory capacity and insulin resistance. And the fourth phase is the final phase in which the diabetes occurs Here, the complete beta cell destruction with the no capacity for endogenous synthesis or release. It is irreversible stage. In more prolonged and severe cases, gossamer respiration, odor of acetone in breath, often abdominal pain or rigidity, cerebral abundation, and ultimately coma will occur. Neither diagnosis. Most of the type 1 diabetes mellitus children have classical triad such as polyuria, polydipsia, and polyphasia. The investigations are required such as urine examination for sugar benedict test is required for acetone, ferric chloride, and Rother's test are differential diagnosis. The renal glycosuria, it may be an isolated congenital disorders, manifestation of the Fanconi syndrome, other renal tubular disorders due to severe metal intoxications, ingestion of the certain drugs which is outdated such as tetracycline, inborn error of the metabolism such as cystinosis. We can see blood sugar. It is of three types. In the fasting phase, we can measure the blood sugar. The random sampling, whereas the patient comes to us, then we measure the blood sugar, then it becomes random blood sugar. And third one is the oral glucose tolerance test, where we have give the oral glucose in a dose of 1.7 gram per body weight in an ideal body weight of the children, and it is rarely needed to confirm the diagnosis in children. But where there is suspicion, then we go for the oral glucose tolerance test. Now we come to the fasting blood sugar level. It having the three blood sugar levels, where is the suspicion as well as the suggestive and the confirmation of the diabetes mellitus. When the blood sugar level above 160 mg per deciliter, then it confirms the diagnosis of diabetes mellitus. When the blood sugar level between the 126 to 160 mg per deciliter, then it can be a patient have a diabetes mellitus. And if the blood sugar level between the 100 to 126 mg per deciliter, then it arouses the suspicion of patient can have diabetes mellitus. When the blood sugar level randomly checked and it across the 200 mg per deciliter, then it is indicate the patient have diabetes mellitus. In this slide, we studied about the complication of the diabetes mellitus. The complication of diabetes mellitus are divided on three parts. First is the acute, second is intermediate, and third is chronic, which is rarely reversible. And acute complications are usually reversible, while the intermediate complications are potentially reversible. Acute complications such as hypoglycemia, when the blood sugar level less than 60 mg per deciliter, the cause is due to mismatch in the use of insulin with the diet and activity of the child. Inadequate calorie intake, hyper and sustained physical activity in absence of increased caloric intake, clinical features such as sweating, pallor, trembling, tachycardia, neuroglycopenic symptoms such as drowsiness, confusion, coma, and seizures occur. What should be the management in case of the hypoglycemia? Avoid the precipitating factors. If the child is conscious, then give him sugar, glucose, honey, fruit juice, and carbonated cold drinks offered immediately, which is equivalent to 5 to 10 gram of the glucose. If the child is unconscious, then administration of glucagon 0.5 milligram intramuscular or glucose solution IV. If exercise is a precipitating factor, then reduce the insulin dose. Now the intermediate complications. It is potentially reversible: lipotrophy, limited joint mobility, growth failure, delay in sexual maturation, impaired intellectual development. And the chronic complications are rarely reversible due to micro and macrovascular pathology, usually manifest in the adulthood like retinopathy, nephropathy, neuropathy. These complications in adult age group. What are the principles of the diabetes mellitus treatment in case of the child? First and the foremost is elimination of the clinical feature of the uncontrolled diabetes mellitus, prevention of the diabetic ketoacidosis, avoidance of the hypoglycemia, maintenance of the normal growth and maturations, prevention of the emotional disorders, and prevention of the chronic vascular complication of diabetes mellitus. What are the specific therapeutic objectives of the management? Glycosylated hemoglobin 3 monthly 8% or lower, self-monitoring of the blood glucose daily before each meal and at the bedtime, the fasting blood sugar level between the 80 to 120 mg per deciliter, while the others ones 80 to 140 mg per deciliter, urine testing for sugar and ketones, first voided sample in the morning should not be exceed 7% of the daily carbohydrate intake or 20 to 25 gram of the glucose for 24 hours. Urine testing for proteins, single voided urine at each time. If present 24-hour assessment, then we go for the rapid microglial testing, and the serum lipids, cholesterol, HDL, LDL, VLDL, fractions, and the triglyceride annually should be normal. Thyroid functions, TSH and T4 annually should be normal. Eye evaluation including the fundus annually by the ophthalmologist should be normal. So these seven specific therapeutics objective of the management of diabetes mellitus. Now the insulin therapy daily dose is 0.5 unit per body weight per day divided into two parts. Two-thirds of the whole dose that should be injected before 20 to 30 minutes of the breakfast that comprise of the lenti or the intermittent acting insulin, and one-third part of the rest dose before the dinner that should be regular or the short-acting insulin. We prefer the regular or the short-acting insulin at the bedtime because here if we give the long-acting insulin such as lenti or the intermediate acting insulin, then it can cause the prolonged hypoglycemia, and because of that the patient can die in the bed and because of hypoglycemia. That's why hypoglycemia is known as deadbed syndrome. Dose adjustment of the insulin. Any increase or decrease should be limited to about 10 to 15% of the total dose, and it is generally not more than 6 units per day. About 12 to 16 week insulin therapy may cause improvement that the patient requires no more insulin for many months. In this phase of the remissions, about 5 units of the insulin advisable to continue. For preventing insulin allergy as well as the resistance when the full dose insulin therapy is resumed on the relapse, the parents and children with the diabetes should be educated about the type, strength, purity, cost, and benefits of the insulin therapy, appropriate disposal of the syringe, technique of the injections, selection and rotation of the site for injections is also come to knowledge in the parents and children. Storage of insulin is quite important and it should be known to parents and children. Route of the injection should be subcutaneously where the injection should be given. Then we advise the patient it should be given by the fine needle syringe in the lower abdominal wall or the pen injections, jet injections, or by insulin infusion pump. We can give the insulin to the child. There are two types of the regimen. One is the split or the mixed regimen, and second is the basal or the bolus regimen. Split or the max regimen. According to this, each dose consists of two-thirds lenti or intermittent acting insulin and one-third of regular short-acting insulin. During preparation of insulin for split, a mixed regimen, regular insulin should be drawn into the syringe before longer acting insulin. An accidental introduction of the long-acting insulin into the regular insulin vial can increase the duration of the action of the regular insulin also. So it is clearly understood. First we take the regular insulin syringe. Later on we take the intermittent acting lenti insulin in the syringe. Second is Basal bolus regimen, peak-less long-action insulin, ultra-lentil insulin with a short-acting regular insulin, and given before the three main meals. Ultra-lentil insulin has acting lasting for about 30 hours. This is developing a constant concentration of the insulin consent circulation. What are the exercise and physical activity in diabetes mellitus affected children? These increase the glucose utilization and sensitivity of the muscles to the insulin. The insulin requirement of highly fit children is less and has good metabolic control. The usual exercise includes vigorous walking, jogging, swimming, aerobic exercises, and games like tennis. Now we discuss about the nutritional requirement in the children. Individual dietary recommendations based on the metabolic status, requirement on the basis of age, sex, weight, activity, food preferences, and based on the cultural ground. Food should be suggested. Total energy intake by 55% complex unrefined carbohydrate, 15% protein, 30% fat with less than 10% in both saturated or unsaturated fat. Children with diabetes should be educated on the healthy eating with a high diet fiber in vegetable, fruits and with fibers. Reduced refined sugar from the diet. Fiber should be 20 to 35 gram per day from the food such as vegetable, especially the legumes. Should be daily caloric intake divided as 20% at breakfast, 10% at mid-morning, 20% at lunch, 10% in mid-afternoon, 10% at evening, and 30% in dinner. Because there is certain gap between the mm, night and the morning. That's why the maximum part of the calorie intake should be given at bedtime. If the patient becomes sick, then some guidelines has been given by IAP. In that, we monitor the blood sugar and urine ketones 4 hourly. Do not omit insulin even if oral intake is less. If the blood sugar is more than 250 mg per deciliter, then give the 20% insulin of the daily requirement as plain insulin. In addition to usual insulin doses to be given, ensure meal intake. If not possible to eat regularly meal, semi-solid or liquid diet may be given if the blood sugar is less than 100 mg per deciliter. Sweet liquids may be given, but insulin should not be stopped. Refer to the hospital if there is any ultrasensorium, rapid breathing, decreased urine output, excessive vomiting, anorexia, or the persistent ketosis. Type 1 diabetes mellitus in Ayurveda. It is defined as Madhumeha. In clinical feature of the diabetes mellitus, which is a subtype of the Premeha, but there is no separate description of the Bal Madhumeha like Bal Shosh or the Bal Atisar. And Kashif Samhita has a single reference of Premeha in Vedana Adhyaya 25th. Nidan, all those activities and diet which increase the kapha, mutra and med are considered for the Madhumeha. Doshic classification of the Premeha. Premeha is of three types: Vatas, Pittas and Kafach. Vatas Premeha is of four types. Pittas Premeha is of six types and Kafach Premeha is of 10 types. What are the Samprapti and Ghatak in case of the Madhumeha? Dosh, Kaf predominance, Tridosh, Apan and Vyanvat. Dusha is Med predominant along with Ras, Rakta, Mas, Vasa, Shukra, Oj, Lasika, Kled and Swed. Srotas, Medvah Srotas, Mutra Srotas, Udakva Srotas are involved. Sutradushti is of Atipravarti and Sang type. Sanchar is Rasayani. Agni is Vaisham of Agni या धातु वैषम में अधिष्ठान वस्ती मेदोधरकरा व पवहन उद्भव स्थान Amasya, Am is Medogat. Am produced due to Jatragni and Dhatagni. Vedavasta occurring occurrence of the Upadrav such as Putimas and Primepidika and nature is Chirkari. A specific etiology to Madhumeha. Guru and Destinic diet prevalent sour and salty taste, newly produced grains, sedentary habit, and luxury lifestyle can provoke this disease. Those conditions which aggravate the bath in the patient of the premi may cause Madhumeha if they are not treated early stage. According to Charak Nidan, hereditary characters of the disease are postulated the transmission of Madhumeha from parents to their offspring through Bij dosh. Bij dosh can occur at any level, either Bij, that is Shukra, Bij Bhag at the chromosomal level, or the Bij Bhagavya, that is the gene level. There are descriptions of the Kulaj disease in Charak and Sushrut Samhita, which denote the knowledge of the inheritance at ancient time. Factors for genetic involvement. As per the Sushrut, the factor which are responsible for the genetic transmission is the Kshetra, that is uterus, Bij is sperm, Ambu, watery substance given nutrition to the fetus or the amniotic fluid, Ritu, environmental around the fertilized ovum or the fetus. These are the responsible. Now the conclusion, it may be possibly any disturbances these level of the genetic factors may cause type 1 diabetes mellitus or the Madhumeha in children. What are the role of herbal drugs in case of the type 1 diabetes mellitus? Need to search out safe, effective and cheaper remedies from the huge wealth of the Ayurveda. There are many herbal drugs which are used in type 2 diabetes mellitus, but how it works in the body on modern parameters is not fully defined. Thank you.